Good evening. I'm going to go ahead and pull the conversation to a close for the next hour or so. We want to welcome you. Do we have our online people? It's ready to go. Okay, fabulous. All right. Well, welcome to all of you, our in-person audience here at Saginaw Valley State University, and also to those who are joining us virtually this evening. If we've not met, my name is Heidi Lang, and I serve as the Pre-Health Professions Advisor here at the SVSU campus. SVSU is excited to partner tonight, this evening, with Michigan State University College of Human Medicine and My Michigan Medical Center Midland for our presentation titled Prevent and Protect: Expert Insights on Colorectal Cancer. We are fortunate that we have 3 guest presenters this evening. First, we will hear from Dr. Kristen Bush, who is a colon and rectal surgeon with My Michigan Health Midland, where she has served as the colon and rectal cancer physician leader since 2023. Dr. Bush earned her medical degree from the MSU College of Human Medicine and completed additional training in Portland, Maine, and Salt Lake City, Utah. She is a fellow of the American Society of Colon and Rectal Surgeons. Following Dr. Bush, we will hear from Rebecca McFalda. Ms. McFalda serves as the lead genetic counselor with My Michigan Health Midland, where she has oversight of the cancer genetics clinics. She earned her Master of Science in Medical Genetics through the Genetics Counseling Program at the University of Cincinnati and the Children's Hospital Medical Center in Ohio. Rounding out our presentation will be Ms. Anna Most, also from My Michigan Midland, who is a registered dietitian nutritionist in oncology. Most recently, she also served as the dietetic internship director at Central Michigan University, where she completed both her bachelor's degree with a dietetics major and her Master of Science in Nutrition and Dietetics. Phew. The level of knowledge in this room on this topic is outstanding, and much credit goes to the MSU College of Human Medicine for sponsoring the Your Health Lecture Series and making tonight's event possible. We do have an online audience. We do ask that you would hold your questions to the end, and we will go to both our online attendees and those here with us in person. If you can first join me in thanking our sponsors, MSU, SVSU, and My Michigan, and our guest presenters. And without further ado, we'd like to welcome Dr. Bush forward to kick off tonight's public lecture. Thank you.
Well, thank you so much for that kind introduction. I'm so excited to be able to talk to you guys today. I have no financial disclosures relevant for this topic today. Some objectives like we talked about, we really want to focus on prevention, risk factors, treatment for colorectal cancer. So a lot of people ask me, why care about colorectal cancer? Isn't that mostly for older people? And we used to say it was. We used to do screenings for colorectal cancer between the ages of 50 and 75. But you may have seen in the popular news that there's a lot more incidence of colorectal cancer in younger patients. So this was an article from just last year. It's been kind of more in the popular press for the past 10 years about the rise in colorectal cancer in young adults. And the scary thing is that we don't really know why. We're not sure if it's related to diet, the obesity epidemic, exercise, genetics, environmental. Are we just better at screening younger patients now than we were 50 years ago? It's probably a combination of a lot of those, but we don't have a clear answer quite yet. You may have also heard a lot about popular people, people in the press and in the media who have died from colorectal cancer. So this is just a small smattering of people. So Chadwick Boseman died from metastatic colorectal cancer at age 43. He played Black Panther in the MCU. Broadway actor Quentin Oliver Lee, he was the Phantom in the Phantom of the Opera for a North American tour, died of colorectal cancer at age 34. And then just this week, James Vanderbeek, who was Dawson in Dawson's Creek, announced that he was being treated for colorectal cancer, and he is age 47. So a lot of people under the age of 50 who have diagnosed, been treated, or passed away from colorectal cancer. So because of that, 45 is now the new 50. So back in 2021, the U.S. Preventive Services Task Force recommended screening for colorectal cancer in adults starting at age 45. Historically, we had started at age 50. So we now say that 45 is the new 50 for these screening recommendations. Lots of different risk factors for colorectal cancer. Some of them you can control and some of them you can't. So some of the things that you're not able to control is increasing age, because again, we still see a lot of colorectal cancer as you get older. Family history or personal history of colorectal cancer or polyps does play part of your risk. People who have been diagnosed with inflammatory bowel disease, so things like ulcerative colitis or Crohn's disease, are at higher risk. And then genetic syndromes, which Rebecca will go into more during her presentation, also put you at higher risk for colorectal cancer. There are things that you can control, though. So things that we do notice have an increased risk of colorectal cancer that you can factor in. So things of like lack of regular physical exercise, a diet low in fruits and vegetables, and Anna will talk more about this during her presentation, high fat diet, a diet high in processed meats, being overweight or obese, and then alcohol and tobacco use in excess all increase your risk. So again, we recommend colorectal cancer screening in all adults ages 45 to 75 years. Between the ages of 76 and 85, it's kind of selective. It's a little bit of a gray zone is what I tell my patients. It really depends on your health and your overall life expectancy, because typically colorectal cancer is a slower growing cancer. So we do the screening to remove small polyps before they turn into cancer. So when someone who's maybe not expected to live for 5 years or more, then doing colorectal cancer screening in them might not be the best use of their time or resources. We also have some people who start sooner for colorectal cancer screening. So we do recommend starting colonoscopies at age 40 or 10 years younger, at the earliest diagnosis if you have a relative or family history of colorectal cancer. So I have some scenarios here because it can be kind of confusing as far as trying to figure out when you may need to start colorectal cancer screening. So someone with a first-degree relative with colorectal cancer or precancerous polyps diagnosed at any age should start at age 40 or 10 years younger. So say you have your mother was diagnosed with rectal cancer at age 46, you would start your first colonoscopy at age 36. If you had a brother who had a history of a large precancerous polyp diagnosed at age 70, you would start at age 40 for your colorectal cancer screening. Also, if you have two second-degree relatives who have had colorectal cancer at any age, that would put you in that category of screening starting at age 40. I really stress with my patients, it's really important to talk about when you should start screening with your healthcare provider, because a lot of this can be very confusing. A lot of people don't know very much about their family history or details about the family history. So you really need to have a really educated discussion with your primary physician or primary doctor, healthcare provider about when you should start. Because again, those things that put you at higher risk, like Crohn's disease or ulcerative colitis, the family history or the family history of colorectal cancer are going to influence your decision to start sooner. So for definition of average risk, you have to check all of these boxes to be considered average risk. So these 9 boxes here, if you check all of these, you're considered average risk for colorectal cancer. And this becomes more of a factor when we go forward looking at the screening options, because if you're at average risk, you have a little bit more screening options for colorectal cancer versus someone who maybe has a history of ulcerative colitis. They are going to just kind of default to colonoscopies for their screening recommendations. So again, the NCCN guidelines for screening, we say individuals at average risk, their choice of screening modality includes a conversation with the patient and the provider as far as what's going to be the best option for them. Anyone who's at increased risk for colorectal cancer, colonoscopy is really the preferred method for screening. So here are some different options for screening. Again, these are for the average risk patients, and we'll go through all of these a little bit more in detail as far as the pros and cons. So first off is our high sensitivity fecal occult blood test. So this one has a sensitivity of 50 to 75% for colorectal cancer, but only 6 to 17% for advanced adenomas, which is AA in this slide. The specificity is better at 96 to 98%. The nice thing about a fecal occult blood test is that it doesn't require any sort of bowel preparation, anesthesia, or transportation. And if it's negative, you can do rescreening with any modality, again, in 1 year. Limitations for this test is that it does include dietary restrictions, and you need to do 3 consecutive stool samples. And any abnormal test is going to result in recommendation to proceed with colonoscopy for further evaluation. A fecal immunochemical test or FIT testing, sensitivity of 75% for colorectal cancer and 23% for advanced adenoma, so a little bit better than the prior one, the fecal occult blood test, with a 94% specificity. Again, does not require bowel prep, anesthesia, or transportation, and if negative, rescreen with any modality in 1 year. Nice thing with this one compared to the prior slide is can be done with a single stool sample, but again, any abnormal test is going to require or recommendation for colonoscopy going forward. Cologuard test. So this is a multi-targeted stool DNA test based testing. There's a couple different tests, but Cologuard test is definitely the most common one that we hear about in the media. It has a better sensitivity for colorectal cancer at 92% and advanced adenomas at 42% and an 87% specificity. This one can be done with a single sample at home. Again, doesn't require any sort of prep or transportation, so it's very convenient for patients, just like the other options I've gone through already. And if this one's negative, the guidelines differ, but some guidelines say rescreening with any modality anywhere between 1 to 3 years. Again, abnormal result, you're going to be referred or recommended to proceed with colonoscopy. One of the new things on the horizon, so the FDA actually recently approved the next generation Cologuard test, which is going to be called Cologuard Plus. So this one has a little bit better sensitivity and specificity for colorectal cancer and the advanced adenomas, precancerous lesions, with a better specificity at 93%. So this one will be coming, I think, more widespread over the next few months or so, because this article was just from October. So just last month, they announced this for the approval for Cologuard Plus. CT colonography, or otherwise called virtual colonoscopy. So this is like a CT scan that you have to do a bowel prep for, and the CT scan can help detect polyps or masses in the colon. Sensitivity is 96% for colorectal cancer and between 73 and 98% for advanced adenomas. Specificity is between 79 and 93%. This one does not require anesthesia or transportation because you can drive yourself, but you don't need a driver. But you do have to do a bowel prep for this one. You have to have the colon pretty cleaned out to do the virtual colonoscopy. This one you can go longer though. If negative, then you can do your next rescreening of any modality in 5 years. Again, limitations, you do have to do an oral bowel preparation, which is probably one of the most hated things my patients say about the colonoscopy is the bowel prep. So that's a big factor. We do have a little bit limited access in Michigan, so we do not offer this screening modality at my Michigan. I usually send people to Covenant or Grand Rapids are my two common spots. So there's only about 2 or 3 hospitals in Michigan that I can get this test done for my patients. And again, if they see something on the CT colonography, they're going to recommend colonoscopy with another bowel prep to remove any polyp that they may have seen during the CT colonography. So it's considered a diagnostic test, but it's not going to be therapeutic because you can't do anything about the results until you get referred for the colonoscopy. Flexible sigmoidoscopy. So this is what I tell patients are like a half colonoscopy. So you're only looking at the left side of the colon and the rectum. You're not going all the way through to the right side or the cecum of the colon. The screening and diagnostic, it can be done at the same time because if you see a polyp during a sigmoidoscopy, you can remove the polyp. So you're doing diagnostic and therapeutic. This one, you typically only need to do an enema prep. So it's not a full brow prep that you start the day before. You do the enema prep the night before, which is a little bit better tolerated by some patients. And you can technically do this procedure without sedation, though I would say most of my patients really do like the sedation. So they get sedation with the procedure, but it's not a requirement. If negative, you can rescreen with this modality or any modality in 5 to 10 years. A lot of the guidelines do recommend doing, if you're going to do flexible sigmoidoscopy, to also do it with a FIT test, so one of those stool tests, because they have a little bit better sensitivity and specificity when you do the 2 tests together, because you're not looking at the right side of the colon with this test, you're only looking at the left side of the colon. Limitations, there's risk of bleeding and perforation, but less so than with a full colonoscopy. Again, it may require anesthesia or sedation, and we don't let patients drive home the day or after they get the procedure. So you would need a driver if you got sedation for this procedure. And then usually we find any polyps during the sigmoidoscopy, they have to come back for a full colonoscopy because they have to do the bowel prep. So it could result in another test with doing a bowel prep if something was found during the sigmoidoscopy. Colonoscopy, this is considered kind of our gold standard for colorectal cancer screening. Both screening and diagnostic, looking through the entire colon, right side, left side, and rectum. This one is less frequent screening. So if negative, you can rescreen with any modality in 10 years. This one has kind of a lot of work with it. Again, you have to do that bowel prep starting at least the night before. Most patients want to do a sedation, though I do have a few patients that have done it without sedation, but most people tolerate it better with sedation, which means you need transportation and you need to take a day off of work or away from home activities to recover. So it can be very challenging for some patients to have that driver, have to take the day off of work or find childcare in order to do the exam. This one has the highest risk of complications as far as bleeding, perforation with the scope, and then sedation complications. Definitely the most feared complication is risk of perforation, so the scope actually going through the wall of the colon and causing a hole, but it's pretty rare. So I have on here from the literature anywhere from 0.005 to 0.085% for perforation. So some new up and coming things. So we are now going to start seeing more blood-based colorectal screening tests. So not really a new concept. This article on the top is from 2016, where they had a blood test called the EpiProColon. It didn't really catch on very well because it didn't have very good sensitivity or specificity for testing. But just over the summer, they did approve FDA approval for Guardian Shield test, which is a blood level test for screening for colorectal cancer. So this one had better sensitivity and specificity. So we may see this one come more on the market, the Shield blood test, which would be really nice for patients. It's just a lab draw. And so as far as those disadvantages of like the CT colonography or the sigmoidoscopy and the colonoscopy, it's a lot easier for patients to go in, get a lab drawn, and then go back about their day. So I'm really excited to see how that's going to influence some people for their screening options. Another thing that's kind of on the horizon is a colon capsule endoscopy. So we do endoscopy, or we do small bowel endoscopy. So basically swallowing a camera pill that goes through and takes a look at the intestine. They've been researching this as far as can we do this for the colon as well. This one, like I said, it's still on the horizon. I think with artificial intelligence, one of the problems is that you have to look through all those images, and it can take a lot of time for one person to go through all the images to see if they find a polyp or a mass. So with the use of AI, who can maybe select out pictures that are abnormal, and then the physician reads that, this may be more feasible, because I think right now we just don't have the manpower to look through all those images to do this. But again, with AI and the advances with that, this may be something that we see in the near future.
So we're going to now shift gears a little bit and talk about the hereditary forms of colorectal cancer. So most everybody in this room probably learned about genes in school in one way or another. Usually it was taught to us learning about eye color, hair color, hitchhiker's thumb, the widow's peak, like these really, really important things in life. Funny thing is, when I was just this morning, I was waiting for the elevator in Gerstacker, and there were 3 women at the coffee cart talking about, well, you have a widow's peak and you don't. And they were actually talking about widow's peak and how it was genetic. I'm like, seriously, like this is first time I ever heard it in real conversation, but so it apparently does mean something to some people. So obviously our genes they determine our physical traits, our appearance. But, more importantly in the world that I live in is they really, our genes play a critical role in everything our bodies do. And they also, especially if there's something wrong with one of those genes, it can significantly increase the risk of certain health conditions. Consider, as we know, our genes are passed down from parent to child. So that's why families share some of these traits like a widow's peak, but they also share those risks of health problems. So with hereditary cancer, what we're referring to is when somebody has a mutation or an error in one of a specific set of genes that significantly increases the risks for certain types of cancer. And since they're hereditary, again, they can be passed through families. 2 key points to remember is most cancer is not hereditary. So just because you have a mom who had breast cancer or a dad who had colon cancer, that doesn't mean, that you have this gene and it's going to mean something significant for you. But at the same time, it's important to also recognize that hereditary cancer is not really that rare. Recent studies looking at all across the board, everyone diagnosed with colorectal cancer, not paying any attention to age of diagnosis or family history, studies have been shown between 9 and 16% they're finding hereditary cancer mutations, and that's a pretty significant number. And another thing to keep in mind is these mutations not only increase the risk of colorectal cancer, but often the risk of many other types of cancer as well. So these are kind of the more common hereditary colorectal cancer genes that we test for now. The red and the blue here are, they kind of are kind of under the category of polyp conditions, where they're classified based on not only the number of polyps that they develop, but the type of polyps they are. So sometimes these are things that we don't know someone has until they have their colonoscopy, and it's sort of looking at the expression of what we're seeing there can help lead us to making one of these genetic diagnoses. In the green columns here, that's where I'm going to focus a little bit more today, because these are more common, where we don't see necessarily something in a colonoscopy that triggers us right away, like, oh, this is something that, this is one of these genetic syndromes. You may have normal colonoscopies for a long time until you don't. And the ones in the dark green here, I'm going to focus on today. These 5 genes all cause a condition called Lynch syndrome, which is the most common hereditary colorectal cancer that we know of at this point. So what Lynch syndrome is, it's definitely hereditary colorectal cancer. Each of those 5 different genes have a variable level of how high that cancer risk is. But with the most common Lynch syndrome genes, we're looking at about a 60% lifetime risk of colon cancer. So that's a significant increase above the general population. But you can see across the board here, they also have a very similar risk of endometrial cancer. High risks we see of ovarian, of stomach, pancreatic, bladder. There's a whole list of cancers we can see in Lynch syndrome. So sometimes we'll see, we diagnosed people with this hereditary colorectal cancer syndrome where they or their family may not have, there may be no colon cancer there. We may pick that up because of an ovarian or because of an endometrial cancer. So it's can be very surprising for families to learn that they're now at high risk of colorectal cancer, because people tend to think only about the cancers of in their family as what they're at risk for. But with most hereditary cancer genes, it goes beyond that. So when we have these significant increases in cancer risk, we don't want to follow those people the same way we follow the general population or people who just have a first-degree relative or something like that. We want to be much more aggressive. So in terms of increased screening, we do lots of colonoscopies. We start young and we do them often. So usually with the more common Lynch syndrome genes, we're starting in the early 20s and we're doing them every 1 to 2 years. So we're really staying on top of that. So when we see a polyp develop, it can get removed. So hopefully it does not transition into a colorectal cancer. We also do some upper endoscopies looking for some of those other cancer types every few years. And there's screening available for really most of those cancers that are on that Lynch syndrome list that we make more on an individualized basis based on what we see in the family and what gene it is we're looking for, or what gene it is that's present. This is one of the hereditary cancer genes where there are some risk reduction options, especially for females. We can live without our uterus, we can live without our ovaries. So women have that option of doing a hysterectomy to with or without the ovaries, kind of depending on their stage in life and again, what gene is involved, how high that ovarian cancer risk is. But that's a great way to kind of knock off a lot of that cancer risk. And they're also recommending that patients discuss with their physicians about daily aspirin use, as that's been shown to reduce the colorectal cancer risk as well. Sometimes we use genetic testing. If we know someone has Lynch syndrome, it changes how we treat that person when they're diagnosed with a colorectal cancer. It may change what surgery Dr. Bush does in terms of how extensive that's going to be. It may also be important to the oncologist because it can change what treatment options are available, because there's certain medications you can give in certain forms of chemotherapy or immunotherapy that work better in patients with Lynch syndrome than they do without. So it can sometimes help us strategize treatment. Family implications, with every Lynch syndrome gene, you got 2 copies. You got one from mom, one from dad. Lynch syndrome is dominant. You only need a mutation in one of them to have this condition. So every time you have a child, it's a 50-50 chance. Do you pass on the gene with the mutation or do you pass on the gene that's functioning normally? So the risk for children is 50-50. Lynch syndrome is not something that usually just comes up out of nowhere. It's not something that happens sporadically. It's almost always inherited from a parent. So we usually say that, your siblings have that same 50% risk and should look at doing some testing if we identify this in a patient. So what are the key features in a lot of these in the colored columns here those are true of pretty much any hereditary cancer. Earlier age at diagnosis. So being diagnosed younger than typical is one of the red flags we look for colorectal cancer that's before the age of 50. Having cancer more than one separate primary cancer. That could be 2 separate colon cancers, that could be colon plus uterine, or any, a combination of multiple cancers is something that makes us think they might be having like a stronger predisposition than somebody else when we have multiple cancers developing. And then we look for those patterns in families. Do we see some sort of trend going through the family that looks like this could be following some sort of dominant pattern? And those rarer cancers, they're just more likely to pop up when somebody has a hereditary predisposition. So some of those Lynch syndrome cancers like pancreatic or ovarian or even brain tumors. And in the polyp world, anytime we have more than 10 colon polyps, we start looking, could there be something genetic going on here? So who do we test for Lynch syndrome? Right now, the guidelines are, they've broadened them quite a bit in the last couple of years. It used to be very specific to colorectal cancer. They added on endometrial cancer because those are the two highest risks. Now they say really any of those Lynch syndrome cancers diagnosed before 50, you qualify for testing. Anyone who's had a combination of 2 different Lynch syndrome cancers. And then there's some family history things. If you just have 3 close family members with a Lynch syndrome cancer, or if there's only 2, if one was diagnosed younger, those are all things that can qualify for testing. There are some people who are now advocating just test everybody with colorectal cancer. There are also people advocating just test anyone with any type of cancer to see what we can find and what we can learn from here. So what do I do when someone meets criteria for genetic testing or wants to learn more about it? They come see me or one of my colleagues. And what we do in genetic counseling is we start by getting as much information as we can, not only on the patient, but on their family in terms of what is that cancer history, that polyp history, and we try to put together a picture of what could be going on here in the family. And we discuss that with the patient. Like, these are the genes I'm thinking could be playing a role here. We provide a little bit of education on what would it mean to you if we find one of these genes? Like, what would that look like for you and for your family? Because that's really a very common question we see among patients is like, well, I don't know why I'd want to know this. Like, they don't understand the actual benefit of going through testing. So we kind of explain and give them some ideas. Well, if you had this, and this is what we would recommend you do for your daughter, this is what we would recommend, and they can kind of pull it together and make sense to them. So we go through all that information. We go through how genetic testing works, what the benefits, what are those limitations, and what potential harms are there, concerns going around with genetic testing. And really the whole goal of the session is to help that patient make an informed decision about, do they want genetic testing? Is this right for them? For patients who decide they're going forward with testing, we coordinate the testing for them. Sometimes patients are like, nope, still not interested. This is not something, like, mentally, I don't want to deal with this. And in that case, we just look at the family history or the personal history, and we make medical management recommendations based on that. So it's really trying to figure out what's best for that patient. And then for those who do pursue testing, when the results come back, we have another follow-up conversation with that patient, going over their test results, what that means for them, what that means for their family. If they're positive, kind of helping coordinate what are the next steps for them? What do they need to do for their health? What do they need to tell their family members? How do they get that information to them? And kind of help them sort of go down all those different roads. So again, I mentioned the benefits of genetic testing. So the number one thing it does that kind of helps families a lot, if they have these really strong family histories, gives them an answer. Like, this is why we've seen this in my family. This is why everybody's dying of this cancer or something. It kind of gives an explanation as to the why. It helps us identify who has the mutation. So if we can figure out who in the family has one of these high-risk mutations and who doesn't, then we don't need to be doing colonoscopies on everybody who's in this family. We can say these people need it, these people don't, and they can kind of go on their way and have their first colonoscopy at 45. It clarifies what cancers they're at risk for. Like I said, that might not be just what's in their family. There may be other cancers that they didn't even know they were at risk for, how high that risk is, and based on all that information, when we really need to start our interventions. So these are the most common questions we get from patients. One, why would I want to know? I mean, we've kind of talked about that a bit here. The next big one is cost. What's this going to cost me? I mean, and genetic testing is not cheap. Fortunately, the labs have really done a great job of coming up with programs to make it very affordable for most patients. It's very rare for a patient to pay more than $250. Most of my patients pay nothing, or less than $100. Insurance is really good at covering testing if they meet any of those criteria in terms of people who should be tested. Their financial assistance programs are crazy generous. You can make a whole bunch of money and still qualify for free testing. So it's cost is rarely an issue in terms of going forward. How can genetic testing be used against me? Like, who's going to have access to this information, and how could that come back and harm me? We have great laws in place. We have state laws, we have federal laws that really protect your health insurance. In the laws really work to say your health insurance they can't change your premiums, they can't drop your coverage. If you switch to a completely different insurance company, it cannot be used as a pre-existing condition. So we want your health insurance company to know you have a genetic mutation, because we're going to ask them to pay for some really expensive stuff to manage you going forward. So we want them to use this information. I feel it's very safe to do that. Where there are not legal protections in place are supplemental insurance policies like life insurance, long-term care, disability. So when we have a hereditary family, I try to emphasize the importance of getting those things in place young. Because once a genetic test results in your medical record, that may really limit your options. Everybody wants to know, when can I test my kids? Most of these hereditary cancer genes with Lynch syndrome, anytime they're over the age of 18, we can test. Usually we say, well, we'll look at testing optimal time is probably when we're going to do something with the information, when it's going to start changing their medical management. So for Lynch syndrome, that's usually by, the early 20s is when we'll look at doing that. But a lot of some parents will push, they want their 5-year-old tested, but you're really protecting that child's future self, their right to make that decision whether or not they want this information, because it's not going to affect them in childhood. So why is family history important? It really helps identify who's at higher risk, not only just cancer, but a lot of health conditions. It helps your providers figure out, okay, who are those higher risk people who should come see me and should look at doing genetic testing. Early when should we be recommending lifestyle changes, or should we well, that's not necessarily something we need to think genetic testing, but we probably should start screening earlier, more frequently, and educating those patients to look for those early warning signs. So it really just kind of helps in preventative medicine to guide you. Coming up a couple weeks from today, November 28th, Thanksgiving, is National Family Health History Day. So the Surgeon General declared this back in 2004. The Thanksgiving, a lot of families get together on Thanksgiving. It's a time to pull out draw your pedigrees and get that information when everybody's together. And not only gather that information, but it's really important to share it with your providers so they can actually utilize the information. So when we're talking about cancer family history, what do we want to know? What are the important questions that you need to ask? You want to know who in the family had cancer. How is that person related to you? Like they'll say, oh, it was Aunt Bonnie. And then you're like, okay, and then they start talking and Aunt Bonnie's like, a 4th degree. It was like this aunt, they call her Aunt Bonnie, but she's related to you like several degrees away. It's like, okay, let's pull this together. So who are the people who've had cancer? What type of cancer they had? You'll hear frequently in families, well, they had cancer of the colon, the liver, the lungs, and they'll just list like a whole bunch. It was metastatic cancer, most likely, trying to focus on, okay, well, where did that cancer first start? Like trying to identify what the primary is, if you can get that information. How old they were, to see if we do have one of those younger ages of onset. And do we know the why? Are there, something like lung cancer? Were they smokers? Did they have any occupational exposures? Has somebody in the family already had genetic testing? Have we already tried to figure out if there's a genetic mutation there? So just the more information families can get, the more helpful your providers can be for you. And there's a lot of ways you can do this. Paper and pencil works just fine. Write it down. It doesn't have to be sophisticated. But there are some tools out there. My Family Health Portrait is through the CDC. There's an online tool you can use, and you can track your family history. They now have also come up with an app specifically for cancer, the MFHP Cancer app, and it allows you to enter family history information. It also allows you to just click a button, enter your mom, and it sends it to your mom, and she has to enter some more information. Like you can send it to family members and bring it back together. So if you're a really techie person, you want to use these tools are out there, but it doesn't, like I said, it doesn't have to be fancy. But and keep it updated. You're going to have Thanksgiving again next year. Anything new, let's add it to that list, and keep your providers updated.
Okay, so then we're going to talk about nutrition aspects of colon cancer. And when it comes to nutrition, really it's about prevention. So with that, we have some objectives about a plant-based diet, our dietary fiber intake, and what are some of the foods that actually increase cancer risk. So the American Institute of Cancer Research has introduced what we call a new American plate. So this is a more plant-based diet where we are looking at trying to reduce those animal proteins in our diet and increase more plant-based foods. So why is a plant-based food diet more important? So increasing plant-based foods like whole grains, fruits, vegetables, most Americans just do not get enough of these kind of things into their diet in general. Trying to increase things like beans, which are very under-eaten in our society. Trying to add more seeds and nuts. So not only adding plant-based foods, but also looking at reducing the high fat, high sugar content variations of those foods. So yes, Thanksgiving's coming up. Apple pie does not count as a fruit.
those kind of things that people kind of make those like, oh, I'm eating apples or I'm eating like blueberry cobbler and all these kind of things. Those would be the high fat, high sugar components that we're trying to decrease in our diet. Well, at the same time, increasing the plant-based foods in our diet, also reducing those animal proteins in our diet, especially meats, trying to reduce eggs and dairy also. So when we look at these plant-based diets, why are they important for us? Plant-based diets promote healthy body weights. And we know that, obesity increases risk factors for colorectal cancer. So we know that body fat increases things like insulin production. We know that it increases cytokines that encourage proliferation of cancer cells, so it just increases our risk. And body fat also increases like inflammatory processes in our body that also increase risk. So plant-based foods, many times we know that these plant-based foods also contain compounds that are more protective for our body. So things like phytochemicals, if you've ever heard those terminologies, phytochemicals that come from things like carotenoids in our food or lycopene, selenium. But the one we're going to really focus on tonight is fiber, because we know that good fiber intake, which is also very underconsumed in our American diet, just having a good fiber intake can reduce our risk. So how much fiber do you actually need? So average American eats between 16 and 17 grams of fiber a day, and we know that we definitely underconsume. So when you look at age brackets, the reason this is broken down into age brackets and we see a decrease with age, because what is recommended is about for every 1,400 calories you consume, you have 1 gram of fiber, okay? Or 1,400, we want to make sure that we're getting enough. So when we look at intakes and all these kind of things, a lot of people think, oh, the older I get, the more and more fiber I need, and that's not true because your calorie intake actually decreases. So men 50 years and younger, 38 grams a day, women 25 grams a day. Women need less because they need less calories. And then we go to those higher above age 50s where we know that risk definitely starts to increase for colorectal cancer. And so those numbers go down a little bit. How many of you have ever looked at the fiber content of your food? Young, healthy people a lot of times just don't think about it. And so it's not uncommon to ask a group of young, healthy people, do you track your fiber intake? And most of them are like, never even thought about doing that, right? Older people, a lot of times they're like, I get my 27 grams a day, and they're like all over it because they know. But looking at our food labels, there is dietary fiber listed there. And so start looking at those labels to kind of say, okay, how do I build up to this amount of fiber that's needed for me? Like I said, average American underconsumes because we underconsume fruits and vegetables. And so we know that those kind of things just are not staples in our American diet, unfortunately. And as we start to increase fiber intake, we also want to increase fluid intake, because if we increase fiber without increasing fluid, we can also have some issues with that. And we don't want to go from, 12 grams of fiber today to 38 grams of fiber tomorrow, because that's going to cause some gastrointestinal issues too. So where do we get fiber from? Our whole grains, our whole foods, fruits, vegetables, whole grains, and beans, like I said, which are super underconsumed. And then when we look at, this is just a kind of a thing that I threw in there to show you some of the really high fiber, from each food category. So like if you go to the top of the list for fruits, like raspberries, a cup of raspberries has like 8 grams of fiber. Or if you go to vegetables, like even peas, having a cup of those, recommendations for fruit and vegetable intake, trying to get 3 cups of vegetables a day, trying to get like a cup and a half of fruit a day. Those are our average recommendations for those. Now, a lot of people will move to things like cereals, because you'll notice like if you get a high fiber cereal and just start your day with that, you can start off with like 12, 13 grams of fiber just with that. So a lot of times people, by incorporating those into your diet just on a regular basis, is a really nice way to start to increase your fiber intake. Then on to, so fiber, phytochemicals in our food reduce risk. However, there are foods that actually increase risk. And Dr. Bush did touch on these just a little bit in her presentation, but the ones we're going to focus on tonight, red and processed meats, alcohol, and added sugar. So red and processed meats, this is a big one. So anything that is classified as red meat, like beef, pork, lamb, the recommendation is to reduce those to 12 to 18 ounces per week. And so, these are fresh meats. So I want to make the distinction between fresh meats and processed meats, because fresh meats, yes, we still want to decrease our intake of those, but processed meats, we really want to decrease our intake, okay? So getting fresh whole meats down to that 12 to 18 ounces per week, while processed meats like bacon, ham, sausages, hot dogs, all of those, luncheon meats. A lot of people don't realize that, like, even though you're choosing turkey lunch meat, it is still a processed meat. And so trying to decrease many of those processed meats, the recommendation is rarely, okay? So how often is rarely? I tell people, eat a hot dog at the 4th of July and have ham at Christmas and these kind of things, but it should be like more special occasion things and not like a daily intake. I see a lot of people that will eat like processed lunch meat every single day. Right? It's a really unfortunate common thing that we do because people think they're making healthier choices. It's like, oh, I'm choosing like turkey and I'm choosing, roast beef, lunch meat that's lower in fat and all these kind of things, but it's all processed, okay? So processed meat increases our risk of colorectal cancer because of these N-nitrosamines that are involved in processing meats. So these bacon, sausages, hot dogs, things like that. And then alcohol. Alcohol, there is strong evidence that alcohol increases the risk of several types of cancer, including colorectal cancer. And so a lot of times people hear these good things about alcohol, right? Have you ever heard like red wine has antioxidants and it's good for you? No. Okay. It's nice to think that, but you're better off eating the grapes, okay? And so when we look at alcohol consumption, it's more related to, people that do not consume alcohol. It is not recommended that they start consuming alcohol for any reason. There's no health benefit that we would say outweighs the risk factors of alcohol, okay? So again, what are the recommendations for alcohol? Rare special occasions, again. It's your birthday or, it's New Year's Eve and these kind of things, but really, and what is actually considered like moderate intake, it's 1 drink a day for a woman and 2 drinks a day for a man, is considered moderate intake by the US standards. However, we really encourage people to greatly reduce that intake. And if you don't drink, don't start. Then limiting sugar. So this is a big one in our American diet too, because most of our processed foods are going to have a lot of sugar in them. So when we look at like sugar intake as a whole, we know that we get an enormous amount of sugar just from those processed foods we eat. And a lot of times, if you have never looked at like added sugars on your food labels, again, it's an area that a lot of people don't really look, but you will notice that there's added sugars even in processed foods that you don't consider sweet, okay? So you might eat Cheerios and you notice it has like 4 grams of processed sugar, but you eat a Cheerio and you're like, this doesn't taste sweet to me, okay? And a lot of times that's because of things like high fructose corn syrup and things like that that they put into these processed foods that add a lot of sugar. So again, most people get plenty of added sugar into their diet because we're eating some processed foods. Men are allowed more than women just because they need more calories. So again, it's based on calorie intake. So what we say is trying to stay under 9 teaspoons for men, and that sounds like a lot, a teaspoon of sugar kind of thing like that. But a teaspoon, of sugar that's adding these grams of added sugar, a lot of times it's not like people just adding sugar to their coffee or adding sugar to their tea. A lot of times people are like, I don't add, 6 teaspoons of sugar to my stuff every day. And I was like, no, you probably don't. But chances are, if you're using that flavored coffee creamer in your coffee and you're drinking, creamer with a little bit of coffee in it, and chances are that's got a lot of sugar added to that. Or if you're drinking any kind of sugar sweetened beverages. And I get this kind of like concept all the time from patients where they're like, oh, I don't drink pop, but I drink Gatorade and I drink these kind of things. I'm like, it's all got sugar in it. I mean, no matter what the sugar source is, a lot of times these sugar sweetened beverages are going to just have an enormous amount of sugar in them. So even just like one 12-ounce can of soda has 39 grams, which is almost 10 teaspoons of sugar, which that even tops the men's recommendation for the whole day in one can of pop. So that means you're not eating any like processed foods with added sugars and you're already over your limit for the day. So definitely sugar sweetened beverages. These are huge, huge sources of sugar in our diet. So when we look at prevention and dietary intake, what we're really looking at is trying to limit processed and fast foods because most of our fast foods are going to be very highly processed, what we classify as ultra processed foods, and trying to increase our fresh food intake. Okay. Include a wide variety of fruits and vegetables and try to get a lot of different colors of fruits and vegetables into your diet. So have you ever heard like the eating the rainbow and doing these kind of things and trying to get a lot of different colors because different colors are giving us different antioxidants, which are protective in our diet. Reducing refined grains. So things like refined breads and cereals and, trying to get those whole grain foods. I was eating something the other day and I was like, this says it has like X amount of grams of whole grain. And it was something that I was like, it might have whole grain flour in here, but this has 0 fiber in it. So how much whole grain am I really getting from this, right? So looking at that fiber content and saying, am I choosing a bread that actually has like 3 to 4 grams of fiber per slice? Because if the package says it still has whole grain, but it has no fiber in it, that means it's been very highly processed. So trying to get more of those whole grains, trying to get more beans and lentils into our diet, which I feel we as Americans really underutilize in our diet. Trying to limit those red meats and processed meats, because those are big risk factors for those. And then added sugar and alcohol, just trying to reduce those as much as possible over the course of, daily intake. I always tell people it's moderation, right? When it comes to food, of course, you're going to have birthday cake on your birthday and you're going to go have a drink on New Year's Eve and all these kind of things. And that's kind of expected as far as moderation goes. But when it comes to really starting to get into those recommendations of reducing, I think the bigger protective factor is try to eat whole foods, try to eat non-processed whole fruits and vegetables, trying to get whole grains into your diet. And a lot of times people think, oh, whole grain is my Cheerios and these kind of things, but you're still looking at those packages and they have 0 fiber in them. So going toward things that actually have good fiber content and are as little processing as we can possibly get. So that is it for that. Thanks.
Thank you to all 3 of our presenters. What we'd like to do at this time is we'll monitor questions that are online, but also entertain any questions from the audience. And we'll start with the in-person audience. Any immediate questions for our presenters? I'm running. We'll go here, and then you'll let me know if we've got online. Thank you.
My question is for Anna, and I was wondering what you might recommend for a diet for a child who has a really difficult time eating fruits and vegetables.
I say start introducing them, make them fun. And a lot of times this is what happens and what I see, especially in school age children and small children, like parents try to get their kids to eat like broccoli, right? And we all just went to the same dinner. And instead of just like giving your child like broccoli on a plate and encouraging them to eat it, give them some dip with it. Give them a little cheese to sprinkle on top of it. Try to urge them to start eating those foods in a fun way, cutting up your little fruits and, trying to get them to do those kind of things. Children tend to be a little more receptive to fruit than they are to vegetables a lot of times. So, getting those sweet things in, even though it's coming from a fruit source and trying to do that. But I say just make them fun. I mean, it doesn't just have to be a plain old vegetable on their plate, and trying to get them to, just accept some. And a lot of times, I think what happens with very small children is parents try to introduce these vegetables to them, and they kind of like turn their nose up at them, and they don't really want them. And then they kind of just give up. I say as parents, studies show that you have to introduce like a new food to a child at least 7 times before they will eat it. And so as you continue to reintroduce and reintroduce and reintroduce, just don't give up. Keep trying to get them to eat them, and just make them very familiar for them. And I say start that as an early an age as possible, because then they are very, like, kids want foods that are familiar to them. And so as we make them more familiar, they're more likely to accept.
How many times do you have to introduce an item to an adult?
Sometimes the adults are even harder because they're kind of set in their ways about not eating those things. So
My question's for Dr. Bush. I was wondering, in terms of the CT, I got done with my family med rotation, and the USPSTF recommended the FOBT and some of the other ones. Is CT just really new? Is that why it hasn't been put at, or does that have like an A rating or a B rating? Because the sensitivity and specificity looked really encouraging. So
Yeah, I think again the problem is that it kind of falls in those tests. It's like you have to do a lot of the work. So you have to do the bowel prep. You have to go there. You have to take time off of work, and then it's going to be diagnostic, but not necessarily therapeutic. So then you're still getting referred. And then, like I said, it's not widely as widely available as like a colonoscopy, because like I said, here in Michigan, there's only about 3 places I can refer people in the state of Michigan to get that test done. So
okay, I appreciate it.
Can I ask a question? I have 2 questions. First off, thanks for all of you for coming in to present. Very interesting topic. Dr. Bush, and maybe, I'm so sorry, I forgot, Rebecca. Okay, thank you. Can answer my second one, but the first question is, suppose individuals that have a colostomy or don't necessarily pass through the colon anymore, is the colon oftentimes at risk of more, or have a higher risk of developing cancer, or less, just due to lack of use? Can you speak to that?
yeah, no, it's a great question. So we still screen, like I have a lot of patients who, let's say like they had a total abdominal colectomy, so they have an end ileostomy, so small bowel, so we don't need to look into that, but they still have their rectum, so they have a rectal stump or a rectal pouch. So in patients who have things like Crohn's disease or ulcerative colitis, they still have an increased risk of colorectal cancer. So we still need to look at that rectal pouch. For patients who maybe had a colonic perforation, for constipation, they're going to be just at average risk like they were before they had the surgery. So kind of the underlying disease process of why they had the surgery that they had does still play into the screening recommendations.
And they still are willing, or they're still it is possible for them to be screened with colonoscopy.
Yeah, like I said, so when I do like someone who has an ileostomy, I don't need to look into that because it's small bowel, but I can go into their rectum. They just do an enema the morning of, and I can look in the rectum. Or if they've had maybe say a sigmoid resection, so they have a colostomy, the colon and the rectum, I have them lay on their side first. I look in the rectum, and then I have them lay on their back, and I go right through the colostomy, and I go through the rest of the colon. Yeah. We get really creative sometimes with the colonoscopy.
Yeah, right.
I can put a scope in about anything. So
Okay. Great. And then one of the screening techniques was SMT-DNA. Can you go into that a little bit more, or Rebecca, do you know anything about the screening of that, or what?
sorry, I missed the first part.
So you said one of the methods for screening for whether an individual needs to be or has a colorectal cancer was SMT-DNA, a SMT-DNA test.
Oh, the Cologuard test.
Yeah, I was just looking at the other parts.
Yeah,
So
so
like,
it's like a stool DNA test. So the Cologuard test is an at-home test, and it's just one of the screening options. It kind of came after the FOB test and the FIT test. The Cologuard is kind of like the next generation, and then after that, the Cologuard Plus, and that's a stool DNA test. So they actually you send in the stool sample from home to the lab, and they actually look for tumor DNA in the stool sample, and that helps figure out your risk as far as it going to be positive or negative.
okay, so yeah,
Yeah.
tumor
Like I said,
DNA.
there's a couple of different DNA tests, but definitely the one that's kind of the most popular, the most used is the Cologuard, and that's the brand name is Cologuard.
Okay, thank you.
Other questions? Yep. You want a hand?
Thank you. Dr. Bush, when looking at screening for family members who have, or for people who have a family member with cancer, or with precancerous lesion, sorry, is there a certain size of the precancerous lesion that you're looking at, or any precancerous?
That's a great question. So the guidelines say anything more than 1 centimeter. So it's always really hard because it's like, again, like at Thanksgiving, they're going to be like, hey, mom, how big was that polyp that you had removed during your colonoscopy? Like a lot of people don't know if the polyp was a 1 centimeter hyperplastic polyp, was it a 1 centimeter tubular adenoma, which is considered an advanced adenoma. So sometimes we have to kind of fudge the numbers. Like if I talk to a patient and they're like, oh, I know mom had like a lot of polyps, or like she had this really big one they were really worried about. Then I kind of say like, okay, you're probably at increased risk, but usually the 1 centimeter is the cutoff for what we consider an advanced adenoma.
And then, is there specific indications for a sigmoidoscopy versus the colonoscopy?
So for indications, I would say the only time that I would sometimes recommend a sigmoidoscopy over a colonoscopy are some of my older patients, because the risk of perforation with a colonoscopy in the age of 85 and older is a lot higher. So if I have someone who's maybe 90 years old and they come in with bright red rectal bleeding, and say they had a colonoscopy, so if they're 90, they had maybe one at 80 and it was normal, I would say maybe let's just do a sigmoidoscopy just to look, because probably bright red bleeding is going to be coming from the lower part, the left side of the colon. So that's really where you have to kind of get down in the nuts and bolts with your healthcare provider as far as like what's going to be the best option. But and anyone just for regular colorectal cancer screening, I'm always a big fan of the colonoscopy, because you're going to look through the whole colon. If you're just doing a sigmoidoscopy, you might miss a right-sided colon cancer if you're only doing a sigmoidoscopy and they had no polyps. Yeah.
Other questions from the audience? I do have a question. I know we've spent a lot of time talking about cancers. What about if there's a colitis? And then are there certain dietary changes that you would do different from what we just heard about if you already know there's been a colitis diagnosis?
Yes. So typically with colitis, you want to decrease fiber intake for a while until that colitis calms itself down. So, we see a lot of intestinal issues that when there's a flare of something, we just want to go to a really low fiber diet. And so your average intake, which I lost my train when I was talking, it's 14 grams of fiber per 1,000 calories. So when you start to like consider how much fiber you need, a lot of times, like if people are following a high fiber diet and they get something like colitis, we try to back up all their fiber. We kind of want to rest that colon for a while.
Thank you. Got another question back here.
Just out of curiosity, and it might be a little bit of a tangent, but I would wonder if anyone could speak to any research that goes into how the microbiome kind of affects cancer risks, because I know that's kind of an up-and-coming area of research. So does anyone have anything to say about that?
And at our Colorectal Cancer Society meeting, we love the microbiome. Like, oh, love it. So yeah, there's a lot of research going in, and they do think that there are certain bacteria strains that maybe increase either risk of colorectal cancer, and we actually care about it a lot for anastomotic leaks, because we do see certain bacteria that can basically hinder when we do a surgery and we do a connection of the colon to the colon, it actually hinders healing, and it's more likely for that anastomosis just to fall apart. So, they looked as far as, should we have patients on certain antibiotics? Should we try to optimize their microbiome? That could be a whole day lecture, and it is at the Colorectal Cancer Conference as far as the microbiome. It's still very new and emerging, but super exciting, and like definitely more to come.
Microbiome in general, you hear about things like probiotics and taking a probiotic to like make your microbiome healthier. And a lot of times what I tell people is, taking a probiotic is taking like an organism into your body, right? I would rather see people working on doing prebiotics, which is it's typically foods that are going to have good fiber content that is actually feeding your good bacteria, because our good bacteria in our intestinal tract feed off those fibers. And so I feel like a lot of times when people have microbiome, deficiencies, it's more related to they're not eating those good healthy foods that are feeding those good bacteria in our intestinal tract. So trying to get things like good fiber intake and trying to get those fruits and vegetables and those compounds into our body on a regular basis. I mean, it's regularity is what it's really all about, consistent good intake of fiber and those phytochemicals that come from our food.
We'll take one more up front, and it better be a good one.
Killing me, Mark. Is this on? Okay. So my question is actually for you, Rebecca. We talked a little bit about this before the presentation, which was wonderful. Thank you all. I was wondering if you could comment a little bit about access to genetic counseling, and particularly as it pertains to colon cancer or certain other cancer diagnoses. I know you have a really strong department within the My Michigan system, but we're a very large area, catchment area. We have a lot of rural patients. How do you meet that need?
I think the problem I see isn't as much of us meeting that need as it is getting the patients recognized in the first place and getting them through the door. Especially we do a better job as a whole with hereditary breast cancer. People are all about hereditary breast cancer, and so those people are talking about it with their physicians. They're all, they follow up on that. We don't see that in colon cancer. I mean, they're estimating we probably only identify maybe 10% of people who have a hereditary colorectal cancer gene. Like, most people are out there, they have no idea they have one of these things, because in part of it, especially when you get into rural areas, it's kind of, the virtual has helped a lot. I mean, that's really been a huge game changer in terms of reaching into the rural populations. And we even do phone consultations. If they can't do the virtual, we just have a phone conversation. So we're doing we try all these different modalities in terms of reaching people where they are, so they don't have to come to us. But like I said, it's just kind of getting them recognized, getting providers to realize the family history. It's got to be all encompassing. Don't just ask about, because if you have a patient if someone comes in with breast cancer and you say, do you have a family history? They don't realize you mean of any other cancer. They think you only care about breast cancer. Patients don't realize that different cancers can make a difference. So it's kind of more that general capture of getting them and getting them here. But it's, we'll always find a way to see them. My whole goal is to just keep making our jobs more efficient so we can see more patients in the same amount of time. So I'll make it work. We just got to find them and get them here. So.
Well, thank you. Thank you to all for coming out. Thank you to those in the online audience. We greatly appreciate our sponsors. We thank Michigan State's College of Human Medicine. We thank My Michigan Midland. And we also thank Saginaw Valley for making this possible. But most importantly, if you'll join me in thanking Dr. Bush, Ms. Most, and Ms. McFalda for coming out this evening.